And this is going to be me sharing my screen real quick. This won't be anything else on there. All right. Just want to do a quick intro of our speakers for our first session today. I can pull this up and it'll let me. I think it's letting me. Can you guys see it?
See your home screen.
I think that's
yeah. Sadly, yes, we can see it.
You can see yourself there. Okay. So, all right. First two presenters today are Matt Zavadsky and Bruce Evans. First, Matt is a Chief Transformation Officer for MedStar Mobile Healthcare in Fort Worth, Texas. He's helped guide the implementation and financial sustainability of numerous innovative programs with healthcare partners that have transformed MedStar fully as a mobile integrated healthcare provider. Most recently, Matt has helped coordinate the negotiations with community partners and payers for enhanced EMS roles, such as COVID-19 vaccination clinics and monoclonal antibody infusions. Matt is also the immediate past president of the National Association of EMTs and chairs their EMS Economics Committee. He has recently worked with CMS, CMMI to help facilitate recent new payment models, such as ET3 model, and Medicare waivers for treatment in place during the pandemic. He has a master's degree in healthcare administration with a graduate certificate in healthcare data management. So welcome, Matt. And our other speaker is Bruce Evans. Bruce is the fire chief at the Upper Pine River Fire Protection District. Chief Evans arrived in La Plata County after serving as the EMS chief and as an assistant chief at the North Las Vegas Fire Department in Southern Nevada. Chief Evans has served at the Henderson Fire Department for 18 years as a fire and EMS captain. He's an NFPA fire instructor level 3 and served as a college faculty member at the College of Southern Nevada's Fire Technology Program, teaching various fire and EMS topics for 21 years. He is currently the president for the National Association of EMTs and was awarded the 2014 Presidential Leadership Award. Bruce is on the board of directors for the Southwest Healthcare Coalition, holds a master's degree in public administration, bachelor's in education, and associates in fire management. Chief Evans has an appointment to the National Academy of Sciences and National Academy of Medicine's Preparedness Committee, and he has co-authored several books. Chief Evans is a contributor to the EMS column in Firehouse Magazine and cases in the Journal of Emergency Medical Services. He is part of the La Plata County Suicide Prevention Coalition and served on the Southwest Colorado Child Fatality Review team. So welcome, Bruce and Matt. I'm gonna stop sharing here and I'm going to turn things over to you.
Awesome. And first, it is such an honor to be here. Bruce brings an incredible depth of knowledge, specifically in the rural healthcare communities, because he currently operates in I would say, Bruce, almost a frontier environment to a large extent, but has also been very active in a lot of the coronavirus activities and brings a unique perspective to this. Am I sharing the right screen? Let's just do that for the first part, right?
Yep, you're good. Yep.
Okay, Bruce, could you test your audio for us to make sure that you're good to go?
Yep, can you hear me okay?
Sounds great,
Perfect.
Sounds great. Nice to see some familiar faces on our Hollywood squares here today. And I want to compliment Romaine. The one note that I wrote down during the lead up to this presentation, you can't see it because of the background, is pee on the stick pregnant. I'm going to have to figure out some way to get that woven into some talk somewhere, because I thought that was probably one of the best comments of the time that I listened. Congratulations for that. So pretty fun. All right, so Bruce and I are going to run through a ton of information. Now, we're going to go pretty quickly because there's a lot of things to cover, but you're in luck because your offices have a PDF version of this presentation, actually much longer than this, that has a ton more information with hyperlinks and all sorts of different things. Bruce and I are going to sort of stick to the highlights and share some of the things that we're seeing happen across the country, specifically in rural areas as it relates to times during, I guess technically we're still during the pandemic and what will likely happen post-pandemic. So Bruce, any introductory comments?
No, again, thanks for having us. It's great to be interfacing with the rural EMS or the rural healthcare folks. And, I think I sent something off to Trevor yesterday about, I popped on just to make sure the technology worked and just got sucked into the conversation. I thought it was very robust, and the critical topics that y'all are engaging with, I can tell you definitely have a pulse on what's happening out there, and I'm just so pleased to hear that things are moving forward, and that there's a lot of critical thinking going on about rural EMS, rural healthcare issues, rural equity issues, all very, very, very powerful stuff. And again, I just popped on to test the technology and wound up staying for a couple hours just listening to the conversation and participating in the town hall.
Awesome. Great opening, Bruce. Okay, so for those of you in your state offices of rural health, the rural challenges for EMS and healthcare in general, but specifically EMS, no surprise, if you have not seen this New York Times article from just last month, end of last month actually, make sure when you get the handout, you bookmark it, Google it, do something, because it really does do a good job for you guys to be able to make the case in your states for funding and issues, because it does do some really high level, but also very personal stories about rural EMS challenges and what's happening and the systems closing and all sorts of things. So feel free to use this, reference it. It does really help quite a bit. A couple of years ago, this was another article that, or another story that NBC News did, talking about the challenges with specifically rural EMS, but EMS in general and the economic models. So please use these as references for some of your messaging with your states and funders and Medicaid office and all sorts of things, because this can really help your rural EMS agencies in your local states. One of the first things that we want to talk about is the workforce. So as Bruce will probably echo here as we go through, recruitment and retention continues to be a big issue in EMS. And part of it, we're going to run through what we think some of these reasons are, and that we hear from our people is that first, there's sort of an expectation mismatch. They see things on television, they see things in the movies, they have an expectation of what the job is, which oftentimes is not necessarily reality. And that causes some dissatisfaction, and people sometimes end up leaving. We are also seeing EMS as a young person's business, a young person's game, if you will. And a lot of the people coming into EMS are millennials. And we love millennials. They're great. They have some really unbelievable skill sets, but stick-to-itiveness is not one of their skill sets. And they're different for us to manage. Bruce and I are dinosaurs in EMS, and we don't necessarily correlate, or we don't communicate well with the millennial workforce. In fact, we often say that, we were those people that we're saying today what probably our managers and supervisors said, 20 years ago. Who are these kids coming into this business? They don't know anything. They're horrible to work with. They're just whatever. So we've become our parents to some extent, and maybe even grandparents. But we need to figure out how to manage the millennial workforce. Also, there's incredible opportunities today in the healthcare arena for both EMTs and paramedics. Hospitals look at paramedics as, and I hate to say it, cheap nurses, because they can do clinical care, even in some cases, beyond what the scope of practice for an RN might be. They're technicians, not clinicians like nurses are. But we've got paramedics in our community and in other communities across the country that are working in emergency rooms and freestanding urgent cares and freestanding emergency rooms that are able to intubate patients, push narcotics, and they're typically much less expensive than other practitioners, so they get sucked into those communities, those work environments where they don't have to, be out in the cold, out in the heat, out in the rain, snow, whatever. So a lot of them end up leaving, and then they get career advancement if they do want to go into nursing or PA school or MD school or whatever, because the hospital systems will generally have those educational benefits for them. What we see typically is a lot of the folks coming into EMS use the traditional EMS role as a stepping stone into another career path. Fire departments, and Bruce can probably weigh in on this in a second, but a lot of folks like going to the fire service because the shift patterns are great. Oftentimes they were 24 hours on, 48 hours off. Now a lot of departments are going to 48 hours on and 96 hours off, so they can have 1 or 2 part-time jobs or other full-time jobs. It's a different career path, full pensions, Bruce, are you seeing that in some of your fire circles with folks that are leaving the traditional or the non-fire EMS and coming into the fire EMS circle?
So what I'm seeing is, so just to kind of give you a current snapshot, we did a testing last week. We had 22 applications. We had 4 people show up for the testing process. Now I would tell you 2 of those people want part-time work. One's a CPA, the other one works full-time for DHS and is just looking for something fun to do on the weekends. One we DQ'd because of a little bit of a psychiatric background. And the other one we just put through to validate the testing, who we got out of the high school program, and is getting ready. We're getting ready to send them off for education and a fire academy. Now I would tell you that yes, people are coming into the fire service. I'm probably a little bit out of the ordinary in that I think the secret sauce we have on recruiting and retention here in a super rural or a frontier area, as Matt said, is that we have immersed ourselves in so many other things. And there was one slide Matt was talking about that the millennials want to feel like their work that they're doing is meaningful. And that, when we go to manage them, their time is so precious to them that if they don't feel like they're making a difference, they're part of a team, or that the work is meaningful, challenging. And then probably the other thing in the secret sauce is that they're growing personally and professionally. They don't stay. It's hard to keep them here. And then in a rural setting, I think the other thing that a lot of the fire departments and EMS agencies are struggling with is that if somebody's going to stay in a rural environment and not gravitate to either a higher paying urban job or maybe a more comfortable equipment, living quarters job in a suburban department, they have to have an anchor to the community. And being involved in the community is very key. And so a lot of our traditional positions, like for example, as a rural fire department, we jumped into vaccinations. We'll talk about that in a little while, but and they got to see the fruits of their labor, and the community was very thankful, and it increased the community acceptance of these people, and they became essentially heroes in a small community, and all over again, and again, a very grateful population where they felt that the work that they were doing was meaningful.
Yeah, very true. And, Bruce, with the advent of COVID, a lot of people were hearing this from across the country, especially in rural areas. It's not worth it. And if you look at a lot of the rural EMS systems, especially ones that might be volunteer-based, the volunteers generally are, shall we say, experienced. They've got a lot of experience, so they're older. And I was just talking with a friend of mine in upstate New York, and they've lost almost half their volunteers because the volunteers were over 65, and they just were totally freaked out about getting the coronavirus and stopped responding to calls. So that, again, becomes a significant issue. Thankfully, in most rural communities, you don't have a lot of civil unrest. I think maybe, Sarah's community in South Carolina there is a little bit different. They've got unrest every, no, I'm just kidding, Sarah, I'm just picking on you. But Bruce is right about the meaningful work. So if they don't see that their efforts are worthy of their time, then they're just not going to do it. We don't know.
Hey, Matt, I just want to add in a little bit about the COVID issue is that, so a little bit of feedback from rural service in Iowa. The volunteers declined dramatically during COVID because their main employers, the people that put food on their table, started giving them pressure that they didn't want them exposed to COVID in their volunteer EMS and fire activities. So the people at the window factory, the people at the slaughterhouses, they were all told, if you're going to volunteer at your local ambulance service and potentially bring COVID into the workplace, we don't want you here. Pick a side. So again, the unintended consequence of the COVID issue for volunteers, that it definitely threatened their livelihood from the main job that they do in a rural environment.
Bruce, that is an excellent point. And it not only applies to that scenario, but people who work multiple EMS jobs. And we had to do that here at MedStar, where people were working full-time here and part-time somewhere else, or they were working full-time somewhere else, part-time here. the full-time employer told them they had to stop working their part-time job, because if they did contract the coronavirus, then the question was, which job did you get it from? So a lot of them just said you can't work your part-time job until the public health emergency is over. And a lot of organizations rely on those people. So yeah, excellent point. So there are a lot of openings for EMTs and paramedics across the country, and EMT is working with a number of partners to actually get the federal government to start accurately counting how many EMS practitioners there are. The Bureau of Labor Statistics doesn't do a really good job at that right now, but we're hoping that with some of this federal legislation, we'll be able to convince them to do a better job so we can actually know how many practitioners there are. But obviously, huge opportunities and a lot of vacancies. The other thing that's interesting about this workforce is that they want a lot of interaction with their supervisor. When millennials are polled or they're asked about job satisfaction, they say that they want at least 2.5 interactions with their supervisor per day. And EMS is the type of a work environment where if you see your supervisor, 1 or 2 times per week, it's typically a lot. So like for us, we had to change a bunch of our processes to try and make sure that everybody working got to see a supervisor at least once, just to say, hi, hey, great, doing a great job. Thanks for showing up today, whatever. But again, it's just a very different environment for those folks. You got to figure some of that out. Some of the strategies for this one is really looking at the fact that EMS is healthcare, and we say it all the time, and really maybe using that as a differentiator in some of your recruiting and your retention strategies, involving them more in the healthcare system, doing things that Bruce talked about with vaccines and maybe even monoclonal antibody infusions, and having them do community paramedicine, mobile integrated healthcare, and really making the career path into the healthcare world more so perhaps than the public safety world, de-emphasizing that adrenaline junkie as opposed to you're just going to do nice things for great people who need access to healthcare. One of the things that a lot of agencies do, and this may be a little bit harder in some of the rural areas, but you still got to do it, is ride-alongs and being a clinical site for training programs. Here, we're an urban system, but I know a lot of suburban and some rural areas where they are the clinical site for EMT and paramedic programs. If those students have a good experience during their internship, then they are more likely to come back and apply for a job there. We do a hiring academy every quarter, and I would argue probably 25 to 30% of the people in that academy had their first experience here through their training program, and they enjoyed it and they wanted to come back and they decided to work here. So something that you could do well, and figure out how do you do those community partnerships, like Bruce said, with some of the coronavirus activities, but also just fun stuff. Things that we're doing for EMS Week is we're having a capture the flag game here. And oh my gosh, I have never seen the interdepartmental camaraderie and the level of running around and laughing and things happening around here just because people are competing to see how many flags they can collect from each department with Nerf handguns, which has been a lot of fun. But just making it that fun place to work will help quite a bit as well. Work with your local healthcare organizations. If you have critical access hospitals or you have clinics or others that people can co-work, they can, when they're on duty, they can, help supplement some staff in some of those other resources, especially if they want that healthcare pathway. It's a great way to do that. Figure out some way to help them get into or continue employing them in the rural agency while they are in nursing school or while they're going to paramedic school, maybe even when they go to medical school. Now, most people can't do anything else when they go to medical school, but you might find some of those synergies to be able to do that in some of the communities. We're seeing a lot of organizations start to do student loan paybacks. If you agree to work here for 3 years, 4 years, whatever, each year we're going to pay off a percentage of your student loan that you had for your paramedic class, or if you have a degree, we'll help reimburse you or help pay off some of those student loans. Could work really, really well. Engage the workforce in decision making. It goes back to a little bit of that millennial workforce. They want to make sure that, or they want to feel that their work is meaningful and they're being heard. This is a good way to do that. If you can figure out the 2.5 supervisor contacts per day, good luck. Let us know how you did that. Sometimes that's really hard. Bruce, any additional comments sort of as we go through?
Yeah. Hey, Matt, just to chime in there on that last slide with the issue about medical school, nursing school, and any school. So, one thing that I was kind of a little bit interested to find out is that at least here in Colorado, our Office of Rural Health, interestingly enough, has plenty of funding opportunities for nurses, doctors, PAs, other healthcare technicians, but not emergency medical technicians. And although we have a mechanism to fund EMT training through our Office of EMS, it still gets exhausted, and still there's always other opportunities that need for funding. So one of the things that would be nice as an ask out of this presentation on behalf of NAMT would be for these offices of rural health to look and see if paramedics and EMTs could be included in the funding mechanisms, and maybe there's some federal restrictions on that that are typically offered by offices of rural health. And I know we've knocked on Colorado's rural health door several times, and occasionally we get lucky with a program that, say, funds CPR instructors or something else that we can put in the orbit of EMS. But like I said, I was a little dismayed to find out that paramedics and EMTs weren't eligible for the same funding sources that were funding nurses, respiratory therapists, sonogram folks, or sonographers. So again, I don't know if there's a federal restriction on that, or if it was just kind of a rationalization that EMS is part of the healthcare system versus the public safety system, and that it should be eligible for funding from a rural healthcare organization, rural healthcare office.
Thanks, Bruce. And just a couple of things as we kind of move along here. The preferred hiring, if somebody's goal is to eventually get to a fire department, police department, hospital, partner with those organizations. Is how do they work for 3 or 4 years with you guys? They get some preferred hiring in the other organization. And we already talked a little bit about the school integration, but can they get preferential enrollment status in schools if they want to go to nursing, PA school, et cetera, because they worked with your organization? Come up with some really great flexible scheduling, really helps a lot. We do that a lot here. We've got school schedules, childcare schedules, rotating shifts, rotating schedules, self-scheduling, believe it or not, which has been pretty interesting. Figure out some way to incentivize people to stay once they're there. Sign-on bonuses are great if you can afford it, but oftentimes you want to keep the people that you have. Pinellas County's Sunstar, the public utility there, just for the last couple of years have done a $35,000 quote unquote longevity pay. If you stay there for 5 years, they write you a $35,000 check, which is a little radical, but it's working really well for them. But just know that those are some of the things that are happening around the country. Just a quick word on
Matt.
system. Yo.
Do you have time for a quick question from a attendee?
Sure.
Sarah?
So Matt, you talked about the training sites, specifically the larger urban EMS agencies being training sites. In South Carolina, that is an issue. If we have one of our tech schools, not necessarily like our regional offices that do training, but if we have a tech school that's doing courses, all levels of EMT, and they are looking to get clinical sites at a more urban agency so they can get those certain skills accomplished that they need. There's a lot of pushback from our urban agencies not having the capacity, not wanting to have those training students in and doing ride-alongs, especially if those students who are attending the tech schools are affiliated with a different, more rural agency. Do you have any advice there?
Yeah, steal them. So Sarah, are you saying that the students don't want to or can't come to the rural agency for their clinicals? They go to the urban areas because they get more calls in a shorter period of time?
Exactly.
Yeah, and they may get more calls in a shorter period of time, but they're going to see typically less severe calls because, let's face it, urban areas tend to have more lower acuity calls. Rural areas tend to have higher acuity calls, and technically they could have more patient contacts because they're with the patients longer, especially if there are long transport times. You got to really develop a good care plan for that 30, 45, 60-minute transport. So I think just market for it and just figure out, is there a an experiential way. And in the downtimes, can you just do some other types of training, simulations or scenarios with mannequins that they won't have time to do in the urban settings? I know one of the things that for us, when people do their FTOs, they have to have at least one cardiac arrest that they've run before they can finish their credentialing process. Well, sometimes that's hard. You could be doing field training for a long time, waiting for a cardiac arrest. So we recently switched to doing a pretty realistic simulation of a cardiac arrest where they get dispatched to the call. They arrive at a location where there's a simulation mannequin, interactive simulation mannequin, and they don't even know that it's a simulation until they arrive on scene. They see a mannequin in the bathroom of that facility, and then they run it, and it's evaluated by the medical director. You can do things like that.
Yeah, definitely. I just think that it's interesting that the more urban agencies don't necessarily want to have, they're not jumping at the chance to be training sites for other EMS agencies in South Carolina. That's just something I've seen.
Yeah, it's not terribly unusual, especially if they don't see any benefit because they can't recruit for it, or people aren't going to come there because they're going to stay with their sponsoring agency. So.
Okay, thank you.
Yeah, Sarah, one of our committee chairs, Henry from South Carolina, who's the new state EMS association director there. You could probably reach out to him, and I think there could be some initiative that would go on that he would certainly help you champion to try to break down some of those barriers. And I agree with Matt. Sometimes the rural environment and being with the patient in the back of the ambulance for 45 minutes is a better experience than a 10-minute transport to the hospital. There's certainly a whole different dynamic of the clinical care that has to happen. And then Matt's right, the acuity of the sick people in the rural environment, they're a little more hardier and they don't call until they're truly, truly sick, versus, some of the 911 responses that are more social work calls, or you're just catching somebody that's fallen out of the safety net.
Great point, Bruce. And it was very appropriate, Sarah, that we had Richland EMS here when you brought that question up. And Bruce, you mentioned Henry. That was his former employer there. So, certainly take a good look at your system. Many systems are really beginning to ask this question about, do we really need to have as many units on duty? Do we need to have all ALS? Can we have some really good BLS providers out there? MedStar, where I'm at, we've been an all ALS system for 35 years. Today, we are testing a tiered system with BLS units because clinically, they can do a lot, and a lot of the patients don't need a paramedic. So can you augment your staffing with 2 EMT units as opposed to an EMT paramedic unit, and make the system more efficient, make the paramedics better utilized, because most of the calls are going to go on are the higher acuity ALS calls. You gotta love Dr. Bledsoe. Brian has been around for a long time. He actually is a product of the MedStar system, by the way. He did his paramedic stuff here. And he poses the great questions like, we don't need paramedics, especially in the urban areas, and they really need to be more in the rural areas, and really figure out what paramedics should be doing. And it's not just 911 response. And if it's all they're doing is 911 response, you probably just need an advanced EMT that can do some interventional airway stuff with the King Airway, and maybe some IM epinephrine and some low-level ALS interventions. Those are the ones that really make the difference, but really use the paramedics in more of that healthcare setting, and using them in the rural areas even as community paramedics to improve the health of the community, as opposed to just assigning the ambulance. So one of the things that you could do in some of these rural areas, work with your EMS agencies to figure out, hey, can we do a fly car program where if you want to get ALS out there, the hospital employs the paramedic and the paramedic co-responds with the rural agency, or vice versa. The rural agency employs the paramedic, loans them to the hospital to work in the hospital setting in the emergency department. If they need to run out on a call periodically or go on a mobile healthcare visit or a community paramedicine visit, do that. And there may be some funding for that. The New Jersey system is very unique in that you can't have paramedics that work on an ambulance unless you're hospital based, and they have to be in fly cars, and it has to be 2 of them in the fly car. But their clinical outcomes are really, really good. Can some agencies in the rural area specifically help with facilitating telemedicine? Telemedicine has been around in the rural communities for a long time. And I think it was Romaine, who was having issues with her connectivity. Now with the FirstNet system and new devices that have come out literally in the last quarter that are high power cellular devices that are on FirstNet, it really enhances the broadband access to areas in the rural communities, because you get a much more powerful signal and you can do some of that. Can they do station-based clinics where if they are on duty, or even if they're not on duty and they're going to come into the station, schedule some people to come in and get their blood pressures checked and their blood glucose checked, or listen to their lung sounds, breathing treatments, all sorts of things that you can do to help keep those folks busy. Incorporate a telemedicine component into that oftentimes works really, really well. Some of the things that you'll see here, Bruce is going to talk about the vaccines and perhaps the MABs, but figure out some things that you can help these rural communities do with their EMS system that include the after discharge care, and there's a lot of funding for that, and people are willing to pay that. Can they do some type of an advanced subscription service where they've got the EMS on demand, where somebody can call them at 2 in the afternoon and say, hey, I don't feel well, can you come out and check me? And it's not necessarily a 911 response, but it's something that they can do. And a lot of folks are willing to pay for that. We're testing that here very well. Bruce, you guys have done an amazing job with vaccines and other things in your community. Do you want to talk to the folks about, in a rural community, how this has worked for you?
So I mentioned this a little bit on town hall yesterday. So we're a super rural agency, about 35 full-time and part-time staff, 12,000 people and 264 square miles. Very appropriately, we have been involved in the healthcare coalition, the Southwest Healthcare Coalition, for probably 5 years. We acquired a vaccine fridge long before COVID ever showed up. That was a hand-me-down from the health department. These relationships were all very well established with the health department. They knew us, we knew them. So when COVID came around, the picture you see here is our staff, firefighters and EMTs and paramedics doing COVID testing. So you can see we had this set up as an assembly line. We started doing COVID testing in September of 2020. And then we were, you can see here that, the health department supplied all the stuff. The health department came by and made sure we were doing the right thing. And basically they stayed for about an hour and signed us off, and then we were on our own for the next few months doing COVID testing. Now, we were an offshoot of the health department. We were putting stuff directly in the health department's computers. All the patient data was going directly into their data management system via our iPads. The 2 guys you see in the upper corner there by the red truck are actually putting data directly in wirelessly to the health department's computer system. Next slide there. So, and healthcare coalitions have been focused a lot on, and rural health offices have been focused a lot on patient movement, going from a rural environment into an urban environment, a specialty center. Somebody with a head injury, somebody with that may need a cath lab or an interventional radiologist. But in all honesty, this time I think there was an opportunity for rural agencies to supplement the urban agencies. What you see here is we are typically in an area where there's seasonal migrations from tourists. And in this particular situation, our call volume was down, so I had plenty of extra staff that was able to go out on deployments. This is one of our fire captains here in Memphis, Tennessee, who was deployed down there for a shock clinic with 2 other firefighters. And he's instructing this National Guard or this Marine Reserve unit that came in on how to do vaccines in this slide. Next slide. This is the back of one of our ambulances that went from San Antonio over to Del Rio, Texas, during a COVID outbreak, and when COVID was really devastating Del Rio. They took a bunch of supplies from the FEMA stockpile in San Antonio to deliver over to Del Rio. They were there for 30 days, so I was able to afford to send an ambulance there. So again, the concept of patient movement and resources flowing, the patients having to move into an urban system versus the resources from a rural system being able to supplement an urban system. And some of this I would have to tell you is because we vaccinated early. Much like Matt was saying, we started vaccinating our community on January 10th of 2021. and we're struggling to find anybody else now to get it. The other thing that happened is when EMS was doing the vaccines, it also reduced vaccine hesitancy. When they found out that the fire district was the one administering the vaccines, some of our grumpy ranchers and some of our anti-vax community capitulated and came for the vaccine because they trusted the fire district and the EMS organization more than they trusted the healthcare system. Next slide. So we were also first to get our teachers out of the way. So this is all, we vaccinated our entire school district system. And we did it ahead of time. We actually snuck a few of them in before the governor cleared us for that level of vaccines because we had more vaccine than we had people to give it to and plenty of people to put it in arms. So this is our group of teachers, the last group that went through to get their second vaccine that were doing a little cheer for us out in the parking lot after they completed their vaccine. So again, one of our, us being essentially the public health arm of for our local health department in a rural setting.
Bruce mentioned it. The local EMS agency is usually a very trusted partner and has great community respect. And we often say now that EMS agencies are really the Swiss Army knife of the healthcare system, and they can do pretty much anything as long as their medical director and agency director and public health department will work with them, and they can go out and do a bunch of different things. They're pretty good at deployment. CMS has also recognized that, and for those of you that may not know, they have issued a ton of waivers for EMS agencies specifically. One of them was this ability to transport patients to non-hospital destinations. This occurred, like most of them, back in April of 2020, and they recognize that, hey, EMS can triage and transport patients to alternate destinations. That's good for everybody. So they've issued that waiver, which for the rural communities could be that they can either take patients to local community resources, especially in areas where you've lost a critical access hospital or your rural health clinic. And EMS can become that to some extent and then bring them to the local doctor's office or whatever you have left available. It could be the clinic that might be still open. But again, there have been, you'll see several reports on this about the risk to the rural healthcare system. We mentioned this a little bit ago. Can there be a station-based clinic? The telemedicine waivers really helps this. So under the telemedicine waiver, physicians and other qualified practitioners can pay ambulance agencies to facilitate telemedicine. We've worked with CMS a little bit on this, and the physicians, if they're getting the right pay structure for this, which in many cases they can certainly reimburse the rural EMS agency for helping to facilitate that telemedicine visit, either at the station or in the field, whatever it might be. And a lot of the concerns about HIPAA and security have also been temporarily waived, which makes it a little bit easier, which allows the rural agency to do home visits and the things that we talked about already. And as we mentioned, transport to alternate destinations, if there are those destinations available in your community. We heard from one rural provider that their medical director also is a primary care physician in their local county. And he told them, hey, listen, if the patient just needs something minor, suturing or an evaluation, just bring them to my office. That's fine. Well, now under that waiver, you can do that, and the EMS agency will still get paid for taking the patient to that physician's office or rural health clinic or really anywhere. We talked a little bit about this already, but again, they could be that telemedicine. That's kind of a big box there, but these things are usually pretty small, and if you have a good FirstNet transmitter, which again, these high-powered transmitters are now out. They are reasonably inexpensive, and they can be mounted in the ambulance or be carried portably to give some additional coverage in those rural areas. This is an example of another waiver that was put into effect by CMS, which again allows the telehealth provision and the physician to be able to pay for the ambulance provider to go out and facilitate that telemedicine. And these are some of those things, again, that people can do in the rural community. Hospital in the home was another waiver that was recently issued that they specifically mentioned mobile healthcare paramedics being able to visit patients and clinically eligible for reimbursement by the primary provider. You can have nurses see the patients on some occasions, physicians see the patients on some occasions that are admitted, but they're at home. And they mentioned mobile healthcare paramedics as being an eligible practitioner to do the in-between visits for those patients. We talked briefly about this, but again, those subscription programs, can you have some EMS on demand services that helps the local community, and folks in many cases might be willing to pay that. We just got this approved through ARPA. The IFC, IAFF, NEEMT, AAA all work together to get language into ARPA that allows Medicare to waive the transport requirement to pay EMS for non-transport, which is something we've been looking at for a long time, been asking for a long time. The definition here is very narrow. The transport, in order to be eligible for reimbursement, the transport had to occur because of a local EMS protocol that didn't transport patients to the hospital, and it had to be part of the coronavirus mitigation. So if Bruce and I were working on an ambulance and our medical director said, hey, if the patient doesn't really need to go, don't bring them to the hospital. We're trying to preserve hospital capacity. They don't have to be COVID related. It could be for anything. If that kind of protocol was in place, then those treatment in place is eligible for reimbursement. And there's just some information here and a reference that you can go to. CMS really wanted to do this. They were trying to figure out how to do it. They told us that they needed statutory authority. So Bruce and I and a bunch of the folks from the other associations worked really hard with Congress to get this language into the ARPA. And literally as soon as the president signed it, CMS was on the phone with us trying to figure out how do they word the waiver, what things do we need, what would they like to have from us in return, and now this waiver is in place. So it's worked out really, really well. Bruce, any other closing thoughts before we open it up to more questions from the participants?
I think one of the things that, from a rural health agency standpoint, EMS and some of these rural fire departments have the opportunity to deliver whatever medical care that you're lacking in your service area. They have the ability to get it the last mile, or in a rural environment, maybe the last 100 miles. So, we're out there, we know the communities, we're connected in the communities. Some of the economies of scale that Matt has mentioned here, treat in place, treat an alternative destination. These are all very complex financing mechanisms to help a rural agency stay afloat and be able to provide these services. And yes, we are, like everybody, facing, staffing shortages, and there's a lot of secret sauce that has to go into that to make people want to be part of your organization. But I think that it's a pleasant surprise to see our legislators and our elected representatives finally waking up to the plight of rural health care. And I know in Colorado, most of our senators have been very attuned to this, and it's now nice to see that it's a national issue that people are feeling has been maybe not at the forefront, but needs to be at the forefront.
Great addition, Bruce. All right, so Mr. or Mrs. Chairman, questions from the group?
Yeah, if anyone wants to put a question to the chat or raise your hand on that participants list, we can call on you. We got about 15 minutes with Matt and Bruce. I think we need to take advantage of that.
Wait, 15 minutes? Why did somebody tell us we only had 45 minutes for the presentation?
We built in 15 minutes for group discussion.
Gotcha.
You want to go? You got more time if you want to keep going. If there's anything else.
For Bruce and I both, we've exhausted the capabilities of our brain.
I like how Ernie Scott in Kentucky said that Scott Helly on their team still serves as an EMT on the weekends, and the stories he tells.
I'm happy to announce that we just started an EMT class 2 weeks ago, and thanks to our interactions with the health department during COVID, we were able to recruit 2 of the San Juan Basin Health Department employees into our EMT class.
And that desire to treat patients and to do things out in the field never leaves you. Bruce is fire chief. He's got, a 75-year career in EMS, and he still goes out and runs calls. I'm still certified. I go out and run calls, literally on an ambulance or in a fly car or bicycle team downtown on weekend nights, because you just love the patient interaction. It's just something that never leaves your blood.
Yeah, Matt, I think one of the other things you brought up in a slide there is the fly car concept. So, just for some of the guest edification here is Upper Pine, again, 264 square miles and 12,000 people. I operate 3 stations with BLS ambulances in them, and then one fly car or suburban concept where there's a single paramedic servicing those 3 BLS ambulances. And that's enough, mainly because of skill maintenance, and again, the acuity of the patients. So, a lot of them are BLS patients or can get by with an EMT with the IV skills and cardiac monitor training, which has been very helpful. But it's an economic model that works for us. It's a skill maintenance model that puts the paramedic on the most critical calls so that they maintain their skills and abilities and their critical decision making. And it makes for stronger EMTs because they're responsible for the patient most of the time.
Yeah, and especially if, as your state offices, you can work with the state medical directors or even local medical directors to enhance some of the scope of EMTs. And many of you may have done this already, but in a lot of communities, EMTs do IM injections, they can do IM epi, they can do breathing treatments, they can do IM glucagon, they can do all sorts of those really sort of beneficial, medium acuity, low risk procedures that either while they're waiting for the paramedic to arrive or in lieu of not having a paramedic, being able to give an asthmatic a breathing treatment through a nebulizer is very, very beneficial, very, very low risk, and something that EMTs can certainly do. In some communities, if their state medical director and scope of practice allows them to do that, it really helps a lot.
Nick, you had a question?
Yes, thank you. I just want to give you both a sincere kudos for facilitating the ARPA and treatment in place agenda. I think that is fantastic. It is there is no denying that EMS and paramedics have been underutilized asset across our entire country for a long, long time. And I think in the wake of COVID, that's one thing has come to light is the fact that we can all be extremely more effective if we coordinate and work together. And I just think in terms of the State Office of Rural Health and our influence in terms of rural hospitals and clinics, if we can continue the momentum and facilitate this coordination and collaborative effort between rural volunteer fire departments and healthcare clinics and facilities that are there, that they're not against each other. It's not no longer is it nurses for nurses. I love nurses, but we're all on the same team, and that's absolutely, if we can continue to cultivate those relationships from our side and continue that momentum, would be fantastic.
Nick, you mentioned that, and we may follow up with you on that, because as we said, this bill only was able to get through so quickly because of the alignment. Now, I will tell you that Bruce and I and others are now taking this to the next level and saying, okay, this was a very narrow scope, makes a ton of sense, and it only is for the duration of the public health emergency. So if it makes sense now, why doesn't it make sense all the time? And let's make this permanent. Let's take out the requirement that it has to be based, only during the public health emergency, because it's good public policy and it's good patient care to reimburse EMS for the response, not the transport. Let's mitigate the case on scene. And, we just did our EMS on the Hill Day a few weeks ago. And I know in the 9 or 10 congressional meetings that I was blessed to attend, and we raised this as one of our legislative priorities for the upcoming legislative year, none of the staff or the elected officials that we met with thought this was an issue. They said, yeah, absolutely, this makes a ton of sense. You mean we're not doing that now? How do we get this facilitated, long-term and making it permanent? So we may find a great window of opportunity, as Bruce often says, never let a crisis go unleveraged, to really make this the new law of the land, where EMS gets reimbursed for treatment in place is just as a standard manner of course.
That would be fantastic, and I would totally support that. And even if we could legislatively, if the agenda could be driven in a direction where advanced or even intermediate EMS is on par with wage indexes that are equivalent to our in counterparts would alleviate a lot of the retention issues. And I know you guys addressed the career progression, which is excellent too. But that, at least in our state, has been a tremendous challenge as far as retention. And as long as the understanding of a underutilized resource, historically speaking, that we can absolutely work in a interagency relationship to fully leverage, especially when it comes to surge capacity potential in the future or otherwise.
Right.
I think that's all fantastic. So thank you both very much for your effort.
Thank you.
Hey, you brought up something that I think is also key, and I'm sure maybe some of the participants are familiar with the research here. When you look at PAs and nurse practitioners that are a lot of times in a rural setting and why they leave a rural setting. And most of the time when you sample those folks, they'll tell you it was a lack of social interactions or the ability to kind of feel like they were part of a team there. And certainly if they're in one of those rural clinics that might be affiliated with a big hospital chain and they have metrics that they're being squeezed on, there's probably no better place in a rural environment that you're going to get social interaction than the local volunteer fire department. It's the people that do the pancake breakfasts. It's the people that are organizing the 4th of July parade. It's the people that are having a charity event for a kid with cancer. And I would just say that in many cases, like I know in the state of Nevada, PAs and nurse practitioners, as long as they take a couple of EMS related certification classes, are eligible to go out on ambulances from the clinic. As Matt had mentioned in one of the slides, EMS being based at a clinic could certainly be a force multiplier for the clinic staff. But that's one of the ways I think to keep a PA or nurse practitioner, or, other healthcare providers that you as a rural EMS office or a rural office of health have invested in. And once their commitment's up, they gravitate to an environment where it might pay more. But I think people would trade that off if they knew they actually had an affiliation with the community. And it kind of goes back to that old time country doctor, Dr. Kopis, who used to be the medical director up at King County Medical One. He talked about when he was a kid, his dad being a doctor and always having to answer the night bell at their home in Minnesota, rural Minnesota, because people would knock on the door in the middle of the night because they knew that was the respected healthcare provider in a rural setting. And that person was an anchor in the community because they were recognized and they had a social group that they were part of.
I couldn't agree more. And in terms of what we could be doing to encourage the hospital CEOs or otherwise to say, hey, look, you have an opportunity to mentor and really cultivate rural EMS here, and them know that you are their advocate as they progress through their career, and any training or coordination opportunities they can be involved in, I think would be tremendous in the future. So thank you all for bringing this stuff to light for us today. Anything we do to help, just let us know.
We will, because the rural, especially in the federal legislature, rural representatives get a lot of respect when they represent large rural communities. So might be really synergistic to do some partnerships.
And are we pretty familiar that everybody on the call here today or on the presentation today is familiar with the Siren Act? And at NAMT, we're we're lobbying very hard to get additional appropriations put into the Siren grant for rural EMS training and rural equipment needs. You know, the original $5 million that was put in that for rural agencies was really kind of just a drop in the bucket of what the need really is out there. So we've asked for another 20 to 25 million to be put in that. We have some sponsorships on it. While the Siren grant passed, you know, appropriations bill can bump that up. So if you get a chance to look into that, you know, you ask what rural offices of health can do to help is certainly, you know, throw their weight behind the Siren Act, because it does provide some additional EMS training and some simulation equipment, a lot of things to connect into remote learning. So really a great bill, just unfortunately underfunded, but it could use a lift. Okay.
Gretchen, did you still have a question? I saw your hand was up and then you put it back down. I didn't know if you still wanted to ask.
It was just a comment. I work for the Office of Rural Health for North Carolina, and I do a lot of metrics and data and things like that. And so I thought it would benefit me to go through an EMT course and get certified, just to see, you know, to talk the same language as some of the people that I'm talking to out in the field. And I took the course and I finished up my clinicals, and I agree with everything everyone's saying. It is, unless you do it yourself or unless you know more about it, it's unreal, and it's such a huge part of the community. I do want to make note that the agency that I did my clinicals with is a hospital-based agency. However, they are a huge member of the community. So like as Bruce was talking about, you know, the firefighters and the pancake breakfast and things like that, most of the people that I worked with said that they had been to several other agencies in the area, county agencies, and they only felt like they were part of a family at this particular agency. So I don't know how they did it, but they have made all of their members feel like they're at home. Their churn is really low. And then also a lot of the students that go there say that they're becoming EMT so that they can go on to PA school. So they're just trying to get their PA hours. And they find that most of those students turn around and go to their medic program. So they run a medic program from the hospital through a local community college, and they send their EMTs there, and most of them turn around to become medics for them and run ALS crews for, you know, a few years into the future. So I think it's really awesome. I think that the connection that they have to the community is really good.
And Gretchen, what kind of bird is that?
I have no, it might be a wren maybe. I had to come outside because my house is too noisy.
Well, it certainly sounds peaceful with the bird chirping.
Yes, North Carolina is this part of North Carolina is very peaceful. And I did want to add too, so where I live, it's not considered, I guess, urban, but it's not rural. And so I actually chose a rural agency to do my clinicals at for the same reasons you guys said, that patient connection. So there's more BLS going on in a 45-minute ride to the hospital than necessarily, you know, in my area where it's like a 10-minute transport. I know in my area, we just have usually a lot of basic stuff that just, you know, direct transport to the hospital. Whereas in the rural area, it was really nice to be able to get more skill, get more training just by working in the back of the ambulance on the ride to the hospital.
And I'll have to say that, you know, being in the back of a rural ambulance, like Matt said, I still take a fair amount of calls. You know, as a paramedic backing up the other single role or the chase medics. You know, when you're in the back of an ambulance with somebody for 45 minutes, you actually get a chance to talk to them. You know, and you get to learn where they're from. You get to learn how long they were married. You get to learn all the secrets of being married for 50 years. And you know, that's really the very rich piece of what we do in EMS is you get a chance to be in an intimate environment in the back of a box for an 8x8 box frequently for 15 or 20 minutes in a transport or sometimes longer. And, you know, it really kind of reflects on what this is really all about. It's about taking care of people and making the human connection and being part of the human condition.
I think that's a great note to end on, Bruce. That was great. We're right at the end of our time here. I just want to thank Matt and Bruce for joining us today, and Bruce for joining yesterday too for a bit. That was great. Any other questions or anything before we take our break? All right, I don't see any. So again, thank you, Matt. Thank you, Bruce. I thoroughly appreciate you guys joining us today. Great presentation. Again, we're getting these posted up onto the website so everyone will have access to them. Yeah, I think it's time for a break. Ended right in time, so we can go ahead and join back in 15 minutes. So I'll let Trevor put up our break slide, and everyone have a good break, and I'll see you back here in about 15. Thanks, everybody.
Thanks for having us again.
Oh, thanks again. Really appreciate you joining us. Trevor, are you good to pull that break slide up, or do you want me to do it?
I'm having a little bit of difficulty pulling it up, but I think,
Do you want me to do it?
I got it. I've got it. Hang on. I can do it now.
Okay.